Okay, so week 5. This is a week we're going to go over 21 and chapters 24, sensory, neurological, muscular, skeletal conditions. There is a discussion question. Make sure you get the first part done by tonight, and then the two peer responses, and then you have your NCLEX questions. You'll always have NCLEX questions the week before the exam, and make sure that you do the proper areas. If you have troubles figuring it out, let me know. I'll show you, or I can send you an example because I do have those up if you need it. Just let me know. I have been meeting with some of you about exam one. Anybody else who wants it, please meet with me. And then if you feel that you could have done better and you want help with exam two, please meet me before next Wednesday. What I suggest you to do is study, the PowerPoint, study and listen to my review. And then if you need more help, you have questions or need reinforcement, asked to get together. I don't care if it's one student or 5 of you together, doesn't matter. I'll be here for you. So let's go ahead and let's get started. So let's start out with chapter 23. There's always objectives there. So let's talk about the ears a little bit, and then again, remember in your review, you're going to see a lot of, different things there too, those key concepts you should know. So remember, the ears are controlled by the eighth cranial nerve. That's the acoustic, which is acoustic means hearing. When a baby is born, they're horizontal, they're vascular. They really don't work with the slight reflex. And remember the thing about why we get these ear infections on the small children. They're short, bigger, and straighter. So that mucus can go straight up into the inner ear and cause things. What does a eustachian tube do? Well, it's ventilation, protection, drainage, and it has to do with a lot about your balance too. So, ear infections, common issues. Well, first of all, we call the swimmer's ear or otitis externa. It's not the inside, it's the outside, and it hurts. And it's, you just even touch the little part of the bottom of the ear, and the child, it really hurts. So, first of all, you need to look, the physician's going to look, make sure the inside looks okay, and make sure there's nothing in there. I have seen roaches in there. I have seen pieces of crayons in there, anything, backs of earrings. So make sure there's nothing in there. Remember, if there's an inflammation, a cellulitis, or even with diabetes, and actually herpes can be in the ear, there's a nerve there. So making sure we look for that. What's the treatment? Well, otitis externa is just eardrops. And of course, something for pain. Mild to moderate pain is always acetaminophen, and it works really well in children. Um, and then sometimes if there's something in there, maybe it's wax or something, it can irrigate it, and then put on those topical antibiotics, oral antibiotics for the media, otitis media, the middle ear infection. And of course, if it happens to be that herpes zoster, that antiviral, because that is a virus. So acute otitis media, common with children. Again, it's because of those short, wide open, straight tubes. And all that mucus the kids don't get rid of, and it goes up into the area of least resistance, those tubes into the ears. So what are you going to see? Well, this child's going to be hurting. Infants will be banging their head or against the thing, or even their hand will be up there trying to hurt it. If you looked inside, you would see red, bulgy tympanic membranes. And the problem with that is if it gets so swollen, it can burst, and you'll see like pus and serous and, sanguinous type of drainage dripping out of it. And it will smell because it is a staph that's there. How do we treat just a simple ear infection? Well, broad spectrum, amoxicillin, augmentin, whichever one the physician feels like. And again, Acetaminophen for pain. Actually, when a child comes in, let's say to the doctor's office, urgent care, they're complaining of pain and ear infection, what is your priority? Pain control, giving them something for pain. That acetaminophen helps. Sometimes heat helps, sometimes cold helps, sometimes don't put anything on it because they don't want it at all. And usually those are the younger ones. So, how do we treat these chronic ear infections? Well, what they can do is make a little hole in it and they could take and put tubes in there, and that can help it from being drained, okay? Because once the pressure's gone, the pain goes away. Now, there's types of hearing loss. Again, it's on your review that you'll be seeing. Congenital, you're born with it. For many reasons it's there. You're small, you're premature, could be an intrauterine infection, or just you're not really born with the connecting places in your ear. Sensory neurohearing is when the cochlea and the nerves are damaged and the hairs that are in there. And this is something that could be due to some infection, some toxin, and so look at that loud noise can damage that hair and prevent that hearing, so decreasing hearing. And then conductive, it's something that prevents that sound from the outside of the ear to go in to the inner ear so that we can hear. It could be earwax, as simple as that. In fact, it's the first thing, hearing loss, decreased hearing. You look in the ears, seeing if there's anything in there, and a lot of times it is earwax, and doing flushing can help that. So, how do we do this and diagnose it? Well, number one, we're going to be doing just routine hearing screens. Um, Infants, they're all get hearing tests before they're discharged today, newborns. And then if we're seeing this is going on where you're calling a child, your loud noises and the child's not responding, especially young infants, that's when you suspect always hearing. Remember, children who don't hear are frustrated because they can't follow directions, right? So these children might have some behavioral problems. So, and remember, hearing and speech are always connected. Can't hear, you're not going to speak as well as you should. How do you treat hearing impairment? Well, it could be that flushing of the ear, or it could be hearing aids up to the point of cochlear implants. They snap this little thing on the outside of your skull and it creates that stimulation, and you can hear it. I actually I heard. I was down at a big center here in Miami for my sinuses, ENT, so it had to do with ears. And this young child just got this cochlear implant, and I could hear mom and the child talking to each other, and I knew what was going on, being a nurse and actually seeing things like this on Facebook or whatever, and I could hear this child could hear and they could talk, and of course, the mother was in tears because now the child could hear her talking. So, in nursing interventions, you have a child who can't hear. Make sure that you're at eye level. I mean, that's always number one, the way that we approach children. Face to face, have a good look in their eyes, and talk in these little short sentences. And don't go over exaggerated and yelling. I mean, there's no purpose. Just very quietly speak in very short sentences and don't try to over talk about the way you move your lips because that doesn't help. Be normal. All right. Critical questions are there. You can go back and look at them if you need help with them. Of course, always see me. So, eye anatomy and physiology. Now, eyes are start about 4 weeks, embryo, starting with eyes in there already. We know when babies are born that their sight is not mature, okay? Actually, each eye works separately. It's called binocularity. You don't need to know that name. I'm just telling you what it is. So this eye works and this eye works, but they don't work together. And because of that, they don't have that depth perception because there's no way to judge where to go. You need the two eyes to get that depth perception, okay? The shape of the eye is less spherical when they're born, and that rounds up as they get older. Tears are not present until about 1 to 3 months of age. Having a young newborn cry, will go through that thing, but their tears are not as present as would say a 1 year old. Types of impairments. So I can't see near, I can't see far. So nearsighted is when you can't see far away. So it's opposite of what it says. That's myopia. Hyperopia is farsighted. I can't see near. Why do they inverted those names? I have no clue. And I've always wondered, but it's the way it is. Strabismus is crossed eyes. They both don't work together and they're sort of trying to focus. So you see them cross eyed, trying to see what they want. And then amblyopia is you have one eye, like that picture of that girl. You see the left eye is a little bit inward. Well, it's a muscle that's weak. So if you patch the good eye periodically during the day and make that bad eye work and strengthen the muscle, it can straighten out with no surgery, no anything. And then there's nystagmus, where they're up and down, sideways. It's this twitching of the eyeballs. It's this really just twitching. One eye, both eyes. So amblyopia, again, all we do is we cover that eye. Sometimes they have to put on glasses, but the idea is to make that weak eye work more, so we make the muscles work. Patch the good eye, let the bad eye work. Strabismus is a type of amblyopia, but they're crooked. The thing is with this one, um, their eyes, they'll be squinting. Again, they're still not seeing together, so it's that depth perception. Again, they'll be taking one eye and they're looking. They get dizzy, they get headaches, and this is when they have strabismus. Now, vision and learning. Now, dyslexia. This is something I even do just typing normally. I switch letters around all the time. But sometimes I've never had it as a child. It's just, the old lady that I am. I do it sometimes, but there are children that suffer with this and really have to work and get therapy in order to be able to not switch letters around all the time. There's something about the brain, it doesn't really process these symbols, okay? Now, eye strain, you're in school, you're working on a computer, reading a book on a computer. This is you, okay? This is when your eyes hurt, they're inflamed, they're aching, you're squinting, headaches, okay? And it does really make it hard sometimes to get your work done because your eyes hurt because you're squinting working on a computer. I mean, not all of you have a 28-inch screen to look at. Some of you have, 10 and 15 inches of a screen, and it does make a difference. Now, conjunctivitis is an inflammation of the mucous membrane, and it's a bacteria, and this is when the bacteria get in, it blocks that lacrimal duct, and it creates this yellow, pussy, crusty, especially in the morning. Wake up and it's completely crusted over. It starts out usually with just some itching and some tearing, and then maybe the eyelid's going to swell up a little bit, and it's bothersome. So the child may have that distracted, irritable thing. So how do we treat it? Well, you take warm compress, you loosen up all the debris, and then you just clean out the debris. Also, you need eye drops or eye ointments. And I always tell you about those eye ointments. Remind the child they're going to blur the vision because young children, all of a sudden you blind them and they're seeing foggy, they're going to be upset. Oh my God, I can't see. Right. And you don't want to do that and stress them. And another thing I'm going to tell you, it's not in any book, but any of you have children that get conjunctivitis, tell the parents to change the pillowcase every night. because they're just going to go back, put their head on the same pillow with the same bacteria. And it's something that can help stop it from being reinfected. Now, hyphema is blood in the little anterior chamber of the common, and it's an injury where it's this little dark red spot that you see. Now, what do we do for this? Well, keep the head of the bed elevated, right? And sometimes medications are put there. But of course, seeing the doctor, making sure there's no problems with visions. Now, a common condition, and it does happen. I've only seen one in my lifetime. It was like an 8 or 10-month-old little girl, as I remember, and her eye looked like that picture down there, and it's called leukocoria. I call it cat's eye reflex. Why do they call it that? Well, ever go outside at night, there's a light on, and you look in the distance, and there's an animal, and you see those white, shiny eyes? That's a cat's eye. That's what they're saying. And with a retinoblastoma, it's a tumor in the retina in the eye. And if you shine a light, you're going to see like that picture. A cat's eye is what it is. Now, it is a tumor. I mean, you might have other issues with it, the strabismus and whatever, but it is cancer. And the only way to cure it is to take the whole eye out and enucleation. And then they need to do radiation therapy and they need to do chemotherapy. So, retinoblastoma, as we're checking eyes, right? We see this white eye, we tell the doctor. Now, the nervous system, what is it? It's our control center, right? This is how our body works. The brain tells the body what to do, how to talk, how to be completely, right? So, how do you monitor neuro things in children? Well, it all depends on the age of the child and what can they do, what can they tell you, etc. But you can inflict pain even on the infant, like you pinch their toe and they withdraw. Well, you know that their brain's working. Their level of consciousness, a big thing, right? If they're alert, they're oriented, following directions, aware of the surroundings, the way that they're moving, if they're posturing, if they're arching their back, these things. In infants, that fontanelle would be big and bulging. Something's going on, especially if you see also other of these things. There's veins in the scalp, in the front and behind the ear here. Actually, they're used a lot when you need to put in an IV and there's nowhere else on an infant. We can put them in the scalp veins. If they're bulging, pressure is pushing from the inside of the brain out. So it needs to be looked at. Of course, ataxia, spasticity, any movement that's not regular, we always worry about the brain. And then moro or tonic neck with withdrawal. So startle reflexes, different. They all look a little different. And these are things that we would monitor in children. Now, if you have a child who all of a sudden is not acting the way they should, they're not remembering your name or they've known your name for 3 months, something's going on. Well, this is an altered state of consciousness. And the definition is a change in the awareness of the environmental stimuli, the ability to react, the cognitive ability to respond to verbal or physical stimulus, of course, in an age manner. That's an altered state. Now, one of the biggest causes is a decrease in blood pressure. Now, why would a lower blood pressure cause you to have a lack of being able to communicate, an altered state of consciousness? Well, what does the blood pressure do? It pumps blood around. What does blood have? It has oxygen. So if you have a lower blood pressure, oxygen's not getting to the brain where it should be. So that's why there's an altered state of consciousness. Again, a lower PO2, or even you're not breathing well and you're retaining CO2. That can cause it. Fever, of course, if it's elevated, you get delirious sometimes with a high fever. Of course, any drugs, sedatives, even the anti-epileptics. I mean, anti-epileptics basically numb the brain so it can't have a seizure, and it does dull the senses. So that can be, of course, seizures after them, that post-ictal state where they're drowsy and they're not aware really well. And then, of course, increased intracranial pressure, maybe from a fall. I mean, one of the things we monitor closely with head injuries is the level of consciousness. If it's decreasing, we know pressure's building in the brain. So those are all your cranial nerves. You all learned them in health assessments, right? It's just a refresher. I'm not giving any questions on every single name of these things, but these are something just to look at for a refresh. Now, neurological monitoring and posturing, the cerebrate and the corticate. Well, I call it decor. Your arms come back to the core of the body. That's how I remember it. The cerebrate is when it gets away from the body. So the core and the cerebrate, flexor and extender. Okay. The other thing is something called opisthotonus. This is where the muscles in the back tend to spasm and their back arches. Sometimes their head can almost hit their buttocks. I mean, they really can arch down. Something's in the brain that's causing this to happen, that the conduction is not correct. Now, Ray's syndrome. What's Ray's syndrome caused by? Well, it's acute non-inflammatory encephalopathy, means something going on with the brain, and hepatopathy, something with the liver. And it's usually after you've had a viral infection and you gave aspirin to this child. At no time would you ever recommend giving aspirin to a child because of the chance of getting Ray's syndrome. Okay. Now, sometimes there's metabolic and other things going on, but the one thing that we have found is not to give aspirin. Next week, you're going to see the one condition that we're going to give aspirin to, but that's extremely closely monitored. Okay. So, why is it after a viral infection? Well, usually there's a fever, right? Plus, the virus decreases your immune system. And then some parents give aspirin. And that's why that's there. Like influenza, one of the biggest ones that you will see Ray's syndrome after. So, sepsis. Sepsis can be caused by what? Well, anything, right? Any infection, bacterial, viral, or fungus. And what happens is it goes through the body and then it causes overwhelming sepsis and shock. And shock can lead to death. How would you know they're going into shock? Well, number one, high fevers. Number two, elevated heart rate, decreased blood pressure, decreased perfusion, decreased urine output. You know, the color of this child goes pale. This is what we would see if we had sepsis that went overwhelming due to bacteria, virus, or fungus. So, meningitis. Remember, meninges is the head and the spinal cord. All of them are covered by a meninge. Don't get that confused with encephalitis, okay? Biggest common mistake in students. So meningitis is the head and the meninges and the spinal cord get some sort of bacterial or even viral infection, and it creates this inflammation. Now, if it's meningococcal, which is a bacterial, many times you're going to see petechiae all over the body. And along with the headache, photophobia, neck rigidity, etc., you're going to know that it is a bacteria. Protect yourself. Always put a mask on if you see that. So, encephalitis is just the brain. Think cephalic is brain, head, right? Cephalic is a head. That's all it is. Meningitis is the meninges in the head and the spinal column. That's a very important concept, okay? So encephalitis is headaches, and drowsiness. And remember, your brain is inflamed. It's getting swollen. It is creating that headache. It's vomiting. The neck's gonna go, and then of course, remember the brain, controls everything. You're say twitching, and your eyes are gonna go, twitching, etc. And that is encephalitis. Now, some of the neurological issues with children, it could be a brain tumor. Now, brain tumors is the second, actually most common of neoplasm in children, and it occurs in the lower part of the brain, which is brainstem, right? So it's a big thing. But remember, every part of the brain controls something. Could memory, speech, ambulation, heart rate, blood pressure, wherever it is, it's going to affect that type of thing. So, very important that we look at the child carefully and look at the symptoms, the signs. What are they showing you? And it can direct you almost to where that tumor could be. Now, how do we make a diagnosis? Well, number one, what the kid looks like, what you're seeing. And then, of course, labs are going to be looked at. We're going to be looking at a CT or MRI. And if you get a CT, if there's a tumor, absolutely an MRI. And of course, we'll be doing an EEG, electroencephalogram, to see if there's any seizures going on here. Now, sometimes, not all of them, we need to do surgery. A lot of times they'll do radiation or chemotherapy first to shrink the size of the tumor. So you don't have to take out too much brain tissue. Okay. So seizures. One of the most common type of seizures is a febrile seizure. It's short. It is when you have no fever, and then half an hour later, it goes up over 102. And that rate of rise is so quick, the brain sparks and goes, oh, I don't know what just happened. And you do have seizures, and it could be arms and legs going. It is short lasting, usually not postictal at all. This is the one that happens and the kid wakes up. Now, epilepsy is more than one a day. It's reoccurrent, chronic seizures. So you can have a seizure, a febrile seizure. It does not mean they're epileptic. That would have to be more seizures happening. So, types of seizures. When you think of seizures, usually you think of the arms and legs going, foaming at the mouth, and incontinent of urine or stool. That is what we call a grand mal or tonic clonic. Usually, the child, the older ones, they'll have this feeling, I'm going to have a seizure. Then they go through the arms and legs going. And when they're done, they go through this, they're confused, they don't know, they want to go to sleep, or a postictal phase is what it's called. Now, a petit molar absent could be that blank stare. You just look, you're speaking to someone, and all of a sudden they're not taking anything in. And all of a sudden they go, oh, what did you say? It is a blank stare, and that is an absent. It calls a temporary loss of awareness. Now, partial or Jacksonian, it's some part of your body. Could be your eye twitch, your lip twitches, one elbow, arm, foot, just one little part tends to twitch, but you remain your consciousness at all times. Okay. Now, atonic is what we call a drop attack, and it's usually you wake up, you start to jerk, and you fall on the ground. It's a collapse, and it lasts up to about a minute. So, what would we do when we figure out we have a seizure? Well, febrile seizure. My first grandson had one at 18 months. What happened? Well, happened 2 o'clock in the morning. They called the ambulance. They went to the hospital. They did a complete workup. Everything was viral. And they said, "Oop, it's a febrile seizure." Now, what happens if it was now it's happening again and again, not related to a fever? Now we got to find out what's going on. Is it a tumor? Is it poisoning? Is it electrolyte imbalance? What is it? So they'll do lab tests to rule all of that. I mean, lead poisoning could cause these things. And kids chew on windowsills of old buildings, right? And there's lead in there, or all sorts of things like that. Of course, they're gonna do a CAT scan, and then, if these seizures are worse, absolutely an MRI is, really necessitated there, and of course, the EEG. And the EEG, electroencephalogram, is looking for any sort of seizure activities. Usually in a hospital, they'll do a 24-hour study looking to see if there's anything during the day. Now, what drug are they put on? It's not like you have a fever, you get Tylenol or Motrin, acetaminophen, ibuprofen. They are so many different types of medication, and they decide the drug to use according to what works and what has the least sort of side effects for that child. We have heard so many things about patients doing diet changes, all different things, gluten and you know there's been so many studies done that work, and something that should be explored if this child is not really responding well to any of the anticonvulsant medications. So, head injuries. What do kids do? They get on top of the couch, they jump, they miss, they fall on the floor, and they bop their head. I mean, probably the most common of head injuries, or they're up on the changing table, they roll off, fall on the floor, right on their head. I mean, these are common occurrences that I've seen many children of many different ages that occurs. So, concussions. Uh, I've seen those, the school age and young adolescents playing baseball, sliding into third base, hitting the head with the knee of the defender and being knocked out. Um, a concussion is noticed to be a temporary disturbance of the brain, and it's followed by a period of unconsciousness. So you get hit in the head and you go to sleep, and then eventually you wake up, right? Now, children's response to a head injury are different than an adult. Now, children, when they get a head injury, yes, they'll have that decreasing level of consciousness, but children usually will vomit. Adults really don't. That's a difference in it. We know that head injuries, there's very subtle clues that we have to really look very closely for. And remember, young kids, the younger ones, the late infants, early toddlers, they can't tell you how they're feeling. Um, that, their head hurts or where it hurt. I mean, they can show you their hands and whatnot, but because of that inability to communicate exactly is hard. Also, they don't want to be touched and felt by us a lot, the medical people and doctors. So these things can hinder trying to get a really good diagnosis on them. But it's important that as nurses, we look and we see, are there any changes? Do they look nauseous? Are they drinking or are they pushing it away? Are they gagging? I mean, nausea, vomiting are some of the keys. And decreasing level of consciousness also can say that head injury is getting worse. Now, shaken baby syndrome. Infants, they're picked up and they're shaken really hard. So their head is being really shuffled. What we'll see is retinal bleeding damage, that subarachnoid, subdural hemorrhages, and you're going to see that cervical spine, get curved. This is something that can cause permanent brain injury. And because it's the cervical spine and your brain stem back there on top of the cervical spine is there, this can cause death to the children because now your heart don't want to beat because the brain is, that brain stem has been really hurt. So what would we see? Well, you see a headache. Well, how do you know they have a headache? Sometimes it's as simple as the kid's touching his head or moving its head against, the bed. And you could see something, or maybe it's the grimacing, that pain looking thing. And it could be fussiness, irritability in a slightly older child. They're drowsy, they don't want to wake up. Blurred vision is hard to detect in the younger child, but vomiting is something you can see, and then you can see if they're getting difficulty breathing, dyspnea. Um, in cases where they've really had a severe shaken baby syndrome, sometimes they're completely unconscious, and you're going to figure what happened here. So near drowning, I live in South Florida. I've seen a few drownings in my life, and I've seen the near drowning where we have saved them. So, an accidental or near drowning is the third leading cause of death in children younger than 19. And what is what we call a near drowning? Well, it's defined as survival beyond 24 hours after they were under the water. Now, the injury of drowning doesn't sometimes show up till 3 days later. So many times you'll get, and I worked in the ER at a trauma center here, and we get a child who was drowning. Somebody jumped in, got them out, did CPR. They woke up by the time the ambulance came, and the parents were like, no, he's okay. No, he's not. Because that drowning caused a hypoxic moment with aspiration of water, and it's caused hypothermia because, of course, the water is always cooler than body temperature. And the biggest thing that we worry about with monitoring these children is respiratory. These children will be admitted to the hospital, even they look like they're fine, because they can go into respiratory distress and die within 3 days of that submersion. So it's a big thing with drowning to monitor them closely. So cerebral palsy, cerebral palsy is something that can happen. It's caused by a lesion, or it's a permanent non progressive motor disorder caused by a lesion in various motor centers of the developing fetal brain. Now, it could be caused by that lesion, or it could be caused by hypoxemia, some hypoxic episode before birth, prematurity, and severe hypoglycemia. Children, especially babies, do not tolerate low blood sugars. So that's why you'll see we're always checking a blood sugar after procedures, making sure that that sugar level hasn't gone down too low. Also why we feed our young infants up to about 2 hours prior to any surgery, because we want to keep that sugar in them, okay? What else can cause cerebral palsy? Well, that shaken baby syndrome, of course. Meningitis and encephalitis, inflammation of the brain. We've damaged the brain somehow. Not all the time, but yes, it can happen. So, what are we going to see with cerebral palsy? Well, one of the reasons why we learn all of these developmental growth and development of what we do and when do we do it and how should we do it is because a child with cerebral palsy is going to be cognitively delayed. They're not going to be, rolling over by 6 months. It could be 9 months. They not may not be walking or never be able to walk. So these are things that we're looking for. It also could be a feeding problem, could be seizures, or their reflexes just aren't what they really should be. So when we think of cerebral palsy, most of us think about spastic cerebral palsy. This is the one the child just shakes really tight, and just, can't control the stiffness and tenseness of their muscles. It is characterized by tension in certain muscle groups, and there's these voluntary movements and jerky movements, that occur. Now, athetosis is that, the hands get in these positions. They're involuntary, purposeless movement. And they go to grab something, but their hands just go in the wrong way and they can't use them. It's purposeless movements. Sometimes we see athetosis when they have high bilirubin, hyperbilirubinemia right after birth. Now, ataxia is the lack of muscle coordination and balance. Child can't walk right, kept falling over, leaning over, needs support to be able to walk. And then, of course, you can have a mixed combination of all these sort of spastic type of things. So, what is our goal with cerebral palsy? Well, a lot of them are cognitively delayed. A lot of them, can't be mobile, but our goal is for them to be the best they can be. So whatever they can do, we're going to do it well. Um, I was working doing clinicals, and I met a little boy, Jonathan. I'll never forget him. 7 years old, spastic cerebral palsy, nonverbal. And that child actually, with a little pad, could talk about shapes and colors, and he could communicate. So 7 years old, years ago, we didn't do that. They were giving speech and physical and occupational therapy. And we know the soonest that we can determine there is a delay, the quicker we can give them more and we could teach them more, which is what we want. An ability to communicate and to be mobile are some big things that we want. Now, what's the treatment?
I have a guy who his mom actually worked with cerebral palsy patients and he ended up having cerebral palsy. So she obviously knew like everything to do for him. And he's probably the smartest guy I know. He's got 2 college degrees, he's been married, like he's insanely talented. He uses an eye gaze to communicate because he can't talk, but yeah, he
That's amazing.
thankfully I think the only reason is he got as far as he did is because his mom was so involved with that growing up.
Early intervention and follow through and the proper therapy. Absolutely. And then remember, there's all levels of cerebral palsy, right? I remember watching a TV show. I don't remember which one, but the cameraman, brilliant at cerebral palsy, and I could tell, by looking at him. So it doesn't mean that they're all, need total care. Thank you, Jessica. That was a very good point there. So all levels. Now, little Jonathan was very spastic. So we needed to do something to relax his muscle. So they use botulism, to try to help the muscles, the drooling, try to help him to eat. But we only put small amounts in his mouth and he doesn't eat that well, but that's the goal. Of course, he has a G tube. And then we use carbidopa levodopa. That's used for Parkinson's, right? And what does Parkinson's is that jittery, and it helps relax it. Of course, anti-epileptic drugs we're going to give because they do have tendency for seizures, Tegretol, Depakote, whatever works. Now, keeping their muscles in a functional position is important. So braces are put on, and then all the stretching and therapies do help. And then because their muscles don't work and they're tight and tense, one of the biggest thing is that aspiration that we worry about and reflux. So that's why the botulism and levodopa, carbidopa to try to help them. So as I said, nursing care are a big thing. Establish a way they can communicate. Because even though they look like they can't, they do have minds that are working. I mean, this little Jonathan would see me and his smile would go ear to ear and his arms would go out because he knew I was coming and I was giving a big hug and a kiss, and he could see me across the room. Nonverbal child in a wheelchair, couldn't walk, but that child did have, something in there. So I used to always go for him. Give him a way to be a locomotive. I mean, ambulating somehow, a wheelchair, electric wheelchair, a walker, a cane, whatever. You want to optimize everything, the motor, intellectual, being around people, other children, technology for them, like that pad where he could talk on the pad with people, and then, of course, all the therapies. So cognitive impairment, it means your IQ is below 70. And we know that the thing with this is we can say that they have a cognitive impairment if they have a hard time communicating, they can't take care of themselves, they can't live by themselves. All of these things are telling you that this child, who, remember, they're going to become teenagers and adults, and what are we going to do and how are they going to live, as they get older. And it's identifying these things to get them the services they need to be able to function as normal as we can. So the nursing care of a cognitive delayed child is always teach the parents. How can we, do therapies, teach them. They're, just because they go to therapy, let's say 5 days a week, they still go home and they still have weeks off. They still have weekends, and the parents need to be taught how to continue these things at home. And with any child, you always concentrate on their strengths and give them that encouragement. Don't say, "Hey, you can't walk yet. Come on, what's going on? Let's walk." Because these children know that. And sometimes they can't even communicate back to you what they really want to say, right? Constant failure, that kid's going to get angry, and you're going to have this child with discipline problems because it's that encouragement on the strengths, and that patience and that repetition and that routine, and that could be make them successful. So chapter 24, this is now muscular skeletal. So what is it? Muscles and skeleton. Well, this is how we get up and move around, right? We know that it's about 4 to 8 weeks of life. All of a sudden, you're seeing, the ribs and the legs and the arms, right? Locomotion develops gradually in an orderly manner, right? We turn over, we get on our knees, we crawl, we creep, we walk, organized. Now, what's the difference between adults and children and their bones? Well, bones as we get older get ossified. They get more they're crisp more, they're hard. Children, they're sort of more flexible. And they're it's harder to break a younger child's bone because they are movable. An older person, you hit it and it cracks. They have a thicker periosteum and it produces calluses more rapid. You put a cast on a 2 week old, it's going to be healed in 2 to 3 weeks. You put it on an adult, it's 8 to 12 to 16 weeks. It heals quicker, and it's really that quick in younger ones. There is a lower mineral content, and it increases the bone strength. And the bone overgrowth is common in healing fractures in children because the child, does that because of the presence of, that epiphysis, that growth plate, and it causes that callus to form so that it can heal. Now, what would you do if you suspect a problem? Well, first of all, it's always that x-ray that you do for sure, and looking at it. The one thing I've always done with children, especially, always the arms, wrists are the always things they break more than anything. They fall, they put their hands out, they break wrists, right? I will always show them the x-rays so they can see where the crack is. Now, sometimes it's more sophisticated than that. And we have to look a little harder to find out what's happening. What if is it that 3-year-old who's limping and you're wondering, and the x-ray doesn't show a fracture, so what's going on? Well, that's when we'll do something called a bone scan. And that's going to look for that septic arthritis or tumors because not everything's seen on a regular x-ray. Also, then we're doing a CAT scan, looking at that. And then more detailed is the MRI. And we could see things like this femoral epiphysis, slip femoral epiphysis, the growth plate's not working right. Therefore, it's crooked. And that's why this limping and whatnot is going on. Also, we have ultrasounds, that we can look at them and it will rule out things like they're limping because there's something in the foot, right? Could be a foreign object there. Also, it looks at is there swelling in the joints? What if it's rheumatoid arthritis that we didn't know about? Maybe it's that newborn where the socket of that hip into the femoral head is crooked. It's up here. It's not where it should be. Those things that we can tell just by a simple ultrasound. So seeing these things going on and with just not a fracture, wondering is it some sort of arthritis or something happening? You're going to do a CBC. We want to look at the white count. We want to see is it something infective going on? Are that white count elevated, right? And then an ESR, an erythromycin sedimentation rate. What that measures is inflammation. It shows infection. I mean, you'll see that elevated a lot in the juvenile rheumatoid arthritis. That elevates when they're in flares. And then the human leukocyte antigen, again, looking at inflammation. So treatment of a bone injury. Well, we can just put a cast on some of the ones. That's the easiest one that's not mentioned. But what if it's a knee? We can go ahead and do an arthroscopy. Sometimes it's shoulders we're looking at. What it is they go in, make a hole, take a camera, put it inside. Let's look at that joint. Let's see what's going on. Let's say it's an osteosarcoma, suspected bone tumor. Well, we're going to do a biopsy. Is it a malignant or is it not? And then we'll do certain things and we'll do traction. Now, for sake of looking at all three tractions and what type of condition would you see these tractions, many of the times these are fractured femurs or where the hip is not in the socket where it should be. Now, Bryant traction is for fractured femurs in children, and it's the picture on top. Now, the child has to be younger than 2 years old and has to be less than 30 pounds, about 20 to 30 pounds. And what they do is they have the child's back on the bed and they have their legs up in the air and it goes to a pulley and a weight and it pulls. And the buttocks is slightly off the bed. And what it does, it pulls that femur up into place instead of crooked. It keeps it from going to the side because that hurts. Also, in those developmental hip dysplasias that don't want to get back where it should be, sometimes they use this traction too on these children that are older. Now, Buck's traction is just they put a boot on the foot and the calf of the child, and it again pulls the femur straight and it goes up to a pulley and a weight, and it's continuous traction that keeps that femur straight until they can do surgery. Because if they let it go, those femurs bones will come apart and they're sharp and they'll get into the muscles and nerves and create severe muscle pain and it hurts. And then Russell traction is the one on the bottom. It's like a Buck's traction, but there's an extra piece on there, that little wrap underneath sometimes the knee or the upper leg, and it pulls it again for a fractured femur, keeping those bones straight to prevent pain, prevent muscle spasms, and to start the healing process. So, what do we need to know about that? All right, so we've got the legs straight, they're in the bed. Number one, those weights should be healing, they should be just hanging, not touching the ground, and they should be checked the number of pounds on that weight. Now, it should be on 24 hours a day, 7 days a week. This child, you can never take it off. All right. You don't want this child pulling at it, manipulating it, because it can, if it falls off, again, the femur bone will disconnect and it will go in the wrong direction. And it's going to go against all of the work that you've done to put some healing on that femur bone. Bed linens and stuff shouldn't be on top of it, should be hanging freely, and remember, don't have the feet on the end of the bed. It should be pulling so that it works. Now, the other thing, make sure the body's straight so that pull is good. Make sure the heels, again, are away from the end of the bed. Now, the other body parts are, you have one leg straight. You can wiggle toes. That's about it. You can't bend a knee or nothing like that. But make sure that the other parts of the body work. Sometimes they'll take and put this trapeze on top where they can pull themselves up, the older kids, so they can pull themselves up themselves. Um, Remember, you worry always about blood clots. So an anti-embolism stocking on the feet. And then the one thing that we need to do, I do it every time you walk into the room, touch your little toes of the affected leg, make sure they're warm, make sure the neurovascular sign's there. And if you see a pale foot, you see no pulse, guess what? You call the doctor. Something happened, blood flow's not getting where it needs to be, and then you could cause that toe, that leg become necrotic. So that's your responsibility. Laying on their back, it's usually a month it takes for this stuff to heal. So making sure that, their skin integrity is looked at, their buttocks, you make sure it's not getting all reddened, and pain relief. This is something you're going to give morphine for. This is moderate to severe pain. This is not an acetaminophen child. This one needs opioids, okay? And you have a child who's immobile, getting pain medicines, worry about constipation. So make sure they have a stool softener and getting fiber in their diet. And as I said, they're trapeze. Now, any neurovascular cast, when we're talking about, the buck's traction, whatnot, our biggest thing as nurses is the assessment, looking for the pain, the pulse, the color, if it's, becoming numb, if it could move. And these things should be documented in your notes. So complications that can happen. Well, of course, we know that putting these casts on can cause, impaired skin integrity. I think the biggest thing and the biggest worry is always compartment syndrome. Because remember, there's still swelling going to be going on. How would we know compartment syndromes is occurring? Well, it's swelling. The color of the toes have turned white. They can't move them. There's severe pain. They feel severe pressure. Something's happening there. So that is something we absolutely report to the physician again. So that should be monitored with all your vital signs every time I walk in. Another thing that can occur is that bottom picture is an external fixation device. And usually there's a bad fracture in there, or sometimes the child is short, one leg, and the other one's, the normal length, and they want to increase the size of the other leg so it's longer. They can break it, open it up, put the device on, it will heal, and that child can gain an inch or two of height when they have a short leg. even short arms, they can do the same thing for that. My medical physician at 50 something just had this done because he had one leg that was shorter and he went through this external fixation device. And remember, those pins inside in a bone can cause osteomyelitis, and you would know that because there's swelling, pain, fever going on, redness. So nursing care of a child in cast, always remember, keep it up on an elevated somehow on a pillow, up on something. Make sure that you're checking the neurovascular signs. And then if you're sending a child home with a cast, they need to know how to take care of it. One of the biggest problems with casts is they get it wet. I had one little boy have a fractured arm, get a cast on, go home, put his bathing suit on, and jumped in the pool as soon as he got home. Yeah. So, guess what the mom had to do? Turn around and go back into the ER. That's not bad. He did it again the next day. So I yelled at him. I said, you know what you're doing? Your poor mother. And it takes what? How long to get through an ER, right? So that poor mother had to keep coming in. Now, he learned the lesson. I didn't see him again. So hopefully that was it. Now, there's bags that we hand out. We teach them how to take showers, etc. If they're on crutches for a leg, make sure they know how to use them and teach them what is a cast, too loose, too tight. So, soft tissue injuries. This is your sprain, right? This is your bruise, your contusion, strains. And what we do is, in this case, is rest, which means stop using whatever is, hurting you. If it's the ankle, if it's the wrist, whatever, stop, rest. Put ice on it. So decreasing the swelling, never heat. Heat will increase swelling. And of course, elevate. And then that compression, ace bandages are the greatest thing to use. So rest, ice, compress, and elevate. So a traumatic fracture is a break, which is caused by an accident, falling off of the monkey bars, right? Falling off the couch onto the floor. And what do you see? Well, first of all, he'll be complaining of pain, and then it's going to start to swell, and it's going to be very tender. And of course, it might have some bleeding going on. Capillaries were ripped, and you might see that bruising, ecchymotic areas start happening. As I said, fractures heal extremely quick in children. Usually your young kids, 4 weeks cast and they're done. And as I said, me, because I'm really old, maybe it's 4 months for me for it to heal. But the younger children do better. It's 4 weeks. It's not as long as older people. And for the reasons that I've already discussed about. Now, fractures, green stick, compound, simple, oblique, and spiral. Now, the pictures show the story, but let's go over them. Green stick is when you have a bend in the bone and a break in the other side. Compound is when it comes out through the skin. And then our biggest concern is osteomyelitis, bone infection, right? That child's going to need IV antibiotics to start with, at least. And then, of course, getting it cleaned out and fixed and put back. A simple fracture is the normal thing. Fell down, wrist is swollen. We need to put on a cast. A simple one. Again, 4 weeks, they're better. Oblique fracture is an angle, and you could see it's a middle bone. It's an angle. It's not a straight across fracture. And then the one that we need to be concerned about is that spiral fracture. This is usually in child abuse, where they take their hand and turn it and pull them really quick, and they can take the wrist and crack it this way. They could take the leg, pull it quick, crack it, and they can actually fracture the femur. So this would be very suspicious of child abuse.
Is that what the nurse's shoulder or nurse's elbow or something like that? Is that what that
That's
is?
a nurse. That's a nursemaid elbow. A nursemaid elbow is a dislocation in the elbow. So when you take and you swing the child around, and all of a sudden their arm goes straight, and they can't bend it back up. The tendons are so soft it pops out. And they just turn it and they flick the arm, choo, and it's back in, put them in a little sling, and then it'll heal by itself. That's a nurse-made elbow. Yes. No. When I'm talking spiral fracture, it is, and they have to pull pretty hard. It is really, you would be very concerned on that child and really look at it. Now, Duchenne muscular dystrophy. You've heard of muscular dystrophy, and what it is a progressive muscle degeneration. Duchenne is males, okay? Usually about ages 3 to 7 is when we see it. And what we see is all of a sudden they are doing different things. They usually have a cognitive delay also, part of it. But all of a sudden, where they were walking, now they're falling down their calf muscles. And the picture there, I mean, I'm talking their calf muscles get huge, hypertrophy. They walk on their toes and they get all of these. Now, remember, any muscle it starts having problems, like even breathing, the diaphragm muscle. Now, what we do with these children when we have this history of motor development is was here and now it's not so good, not progressing, they'll go ahead and they'll do blood tests and they'll look at a CPK level, and that's creatinine phosphokinase. It measures muscle damage, okay? They'll also do a biopsy to look at those muscle fibers. Are they normal or not? And then what they're going to do is an electromyogram. And it sounds like this big thing, but all they do is they take either tiny little needles or just like sticks, like you would put for an EKG, that you put those little tabs. And this machine will deliver an electrical impulse. And we see how long it takes for that muscle to move. And after that is done, and we test the muscles of the body, this child has been like going through a marathon. Their muscles hurt when that is done. Now, slipped femoral capital epiphysis. It's also called a coxavera. And you can see is you've got this hip bone, you've got the femoral bone and the head, and it goes in, and all of a sudden, a piece of it moves. Okay. Many a times, this is at that where the adolescents have that big growth spurt at the beginning of adolescence. And what we'll see is these children all of a sudden will complain of pain or start limping, or they can't put their foot down and they can't bear weight. Now, how do we treat it? Well, we're going to have to rest it, right? Buck's traction holds it straight and it helps with pain. And it's going to need some sort of intervention surgically to get it back in alignment so it stays there. Leg calf birth. Very important diagnosis. What it is all of a sudden there is blood supply for some reason stops going there. It's an aseptic, so no infection, stop of blood supply in the head of the femur. And it causes the head of the femur not to develop correctly, and that head is going to be distorted. And it's usually in boys ages 5 to 12, and it's something that in time tends to spontaneously, over quite a bit of time, heal. Many of these young boys end up with hip replacements as an older person. Bone tumors. Now, I've mentioned osteosarcoma already. I've mentioned the femur. It is a cancer of the bone, and it gets bigger and bigger. It starts out with an ouch, it hurts, it's a limp, it's a kink, and it progressively gets to the point where it really, really hurts. Now, if a child's already had a retinoblastoma, they're at the highest risk for this. Okay. And the thing about bone tumors is, as we see this lymph and whatnot getting the diagnosis because it can metastasize. And of course, then it's usually to the lungs. So it's something that needs to be looked at. What they do is, and if you look at that picture, they take the whole femur bone and leg, the thigh is taken off. They take the bottom part of the leg, the calf, turn it around, and put it back where that leg was. And why do they do it? It's called salvaging the limb. It's because they need a place to put a prosthesis so these children can move around. These are adolescents. Can you think about the body image issues here? But we can at least get them up and we can get them mobile. Then there's Ewing sarcoma, which is a type of osteosarcoma. And again, we always worry about metastasis, and it's treated with chemo and radiation. Um, this osteosarcoma, yes, it's also that radiation and chemo, but it's the surgery. You've got to take that bone out. Ewing's, it's in the bone marrow, so sometimes they can't get that out. Now, JIA, I've mentioned JRA, it is autoimmune, body attacks the joints, connective tissue, and the viscera. And there's three types of it. Systemic is when you have a rash and you see all this inflammation, and it's more than 10 days, very painful. Polyarticular is many places in the body hurt. Your fingers, your elbows, your wrists, your knees, toes, everywhere. And oligoarthritis is four or fewer. Now, one of the things that can occur is, you see that red eye down there on the bottom? It's called uveitis, and it can cause blindness. So these children need their eyes tested, to make sure it's not happening. What's the treatment for JIA? Well, the biggest thing is to stop the pain. NSAIDs are the drug of choice. Your ibuprofen, your naproxen, these are your drug of choice for pain. Um, the thing is to keep and promote mobility and preserve joint function, exercise. And they say swimming is a great thing. Now, I don't know if you all know it, I have rheumatoid arthritis. How do I keep myself moving? I'm in water wherever I find it. And that just, I move, I'm weightless, I keep my body moving, and it does help. When I hurt, I go find water, I jump in a pool, and it helps. Okay. Um, how do we treat it with medicines? Well, methotrexate, weekly injections, steroids when you're really in pain. They're a band-aid. They don't cure anything. They just help with the pain. And then, of course, immunosuppressants. You've heard of Humira, one of the biggest ones, biologics that we use. The torticollis, a lot of times you see that on newborns. We pull their head out in the birth canal, right? Sometimes their sternocleidomastoid gets shortened and it causes a stiff neck. How do we treat it? Well, physical therapy. Remember, sometimes when we see this, um, it also, you have to be looking out for their hips, that congenital hip dysplasia, where the hip joint is not in the socket, it's up higher or any level there. Scoliosis, curvature, S-shaped curvature of the spine. And the way that we usually see it is that the hips and the shoulders are like crooked. Like one of the hips, arms is up, one of the hips is up. When you bend over, one arm is longer than the other. Sports injuries, kids want to be good, they want to be the best, they get up and they go, right? Well, they don't always stretch and do what they're supposed to do. They just run out in the field, and that's when they get hurt. So, how to prevent it? Adequate warm up and cool down, making sure they just don't get up one day and decide to go run 30 miles, that they've been doing a little bit all the time. Again, it's their physical size. Are they large? Are they small? Their maturity, supervision, making sure they're not going crazy, doing too much. Always protective equipment that fits properly. And then if been hurt, that they do take the time to rest. And you'll always see any injury, always good nutrition. Remember, protein is one of the great things for healing, right? And then child abuse, family violence. We've mentioned it, a little bit. Maltreatment is then they're getting not really the degree of care that they need. Emotional is when verbal acts are destroying self-esteem. You're fat, you're stupid, you're dumb, shut up. I don't care what you think. Those things happen in families. Emotional neglect, where they just completely don't pay attention to the child. No hugs, no kisses, they don't talk, they're just there. Sexual abuse, and it's because the adult wants some sort of sexual gratification. Many different things could be sexual abuse. Physical neglect, when they intentionally withhold their basic needs. I saw one little, I don't know how old he was, 7, 9, something around there, little boy whose father tied his son to a mattress in a room with a door locked, and he was in restraints, and he didn't feed him for about a month. He brought him into the ER. He was basically on his last breath. And I was, of course, one Saturday morning, they called me to come in to help, and he coded and he coded and he coded. We got him back. We saved him. I actually saw him a month later. This kid had not a stitch of fat on him. He had decubituses from non-moving, and um, he actually got moved, name changed, everything to protect him. And the person who did it to him got what he was supposed to. He went, into jail. So physical neglect is real. I've seen it, and I've seen horrible things with it. And then, of course, physical abuse, belt buckles, cigarettes, cigar burns, etc. Now, what can cause these things? Well, there's social, child stress, triggers, parental stress. Now, social stress is their poverty, they're homeless, they're unemployed, the family just is dysfunctional, they don't know how to talk to each other, etc., etc. The child's stress. So you have a child who's disabled or temperamental, hyperactive. Sometimes the parents can't handle it and they tend to abuse them because they can't calm them down. It's not the child's fault, right? Or sometimes it's not their child, it's a foster child or stepchild. Those tend to be abused more. Parental stress, sometimes they were abused as a child, or maybe they have low self-esteem, or they're working so hard, they're so overwhelmed, and the kid comes at them and they just lose it out on the kid. Uneducated, and then, of course, any sort of substance abuse can cause child abuse. Now, what is a trigger? Kid did something wrong, and that parent goes after them, but abuses them more than what they should. So that need for discipline is beyond its abuse. Something going on in the family, financial problems always, and of course substance abuse. So our job as nurses, taking care of these children, your job in pediatrics is to keep your kids safe, making sure that if you suspect anything that could be abuse, that you notify the proper person. If you're in a hospital, you notify your charge nurse, you notify the doctor. It's better to be safe than it is for a child to be continually abused, okay? So all people who suspect abuse or neglect are given immunity from criminal prosecution because you did it in good faith. So you have something that protects you for reporting that, okay? Always remember, get a good history and physical because it could be these alternate therapies. What about the Asians and cupping? You might see these big marks on the back of their back. It's part of their cure. who they are. So make sure you don't make those mistakes, okay? Make sure you document it. Make sure you document how these children act with their parents. And then, of course, if you need to, Child Protective Services should be coming in and checking this child and doing a thorough investigation to make sure this child is safe. So, what do we do for the child? Well, you're going to do things to techniques to reduce the anxiety, teach them how to talk up, to be assertive, and how to cope with what's gone on with this abuse. As nurses, managing their feelings, allow them to verbalize, to talk about it, right? That developing what happens if this happens, that problem solving. Who do you call? Where do you go? What do you do? Some children don't know. So that is an important thing with child abuse. I've seen a few cases. I've seen it with young children. I've seen it with middle-aged children. So that is a concern. Lacey, where are you, my dear? I don't see you on camera. And Marn, where did you go? Okay, make sure that you stay on camera. And Jamila, what are you doing over there? Are you cooking? Jamila, can you hear me? Make sure that you
Can you
stay
say it
on
again?
camera, please.
What you say?
Make sure that you stay on camera during class. I haven't seen you. Please. Thank you. Lacey, are you there, my dear? Lacey, if you don't come on camera, I'm going to have to remove you from the class. And I don't want to do that. Does anybody have Lacey's phone to text her to tell her to come back on?
I was in the restroom.
Okay. Well, you didn't send me a message, so I didn't know. So please come back on camera so that we can continue and do our cahoots now. Any questions regarding anything? There's so much on these last two chapters. Again, I did do the review today. You're going to listen to it again, and I think that's going to help re-emphasize those things.
Did you see me? I was having technical issues. I had
Saw
text.
that. You
Oh,
sent me a message. Yes, ma'am. Thank you
thank.
so much. Good communication is all I want. Just tell me what you're doing, if you have to go to the ladies' room, I understand that. So who wants to win a cahoots today? Jessica does. I know you do. And Angela does too. All right, let's keep going here. Oh, Ricardo does. I see you smiling. All right. Let's see if we can get you today. All right. Remember, any questions as we go along? Do not hesitate. You can talk to me. I will answer your questions. So remember, next week is going to be exam 2. Try to come to class a little bit early to get yourself set up. Don't forget to charge your phone and your computer and to have your ID. And if you're going to use your whiteboard, have it there ready to.
Professor,
Yes.
is it mandatory now that we need a whiteboard?
They want you to have a whiteboard for all of your math. You can do this, Paula. Get a baggie, put a piece of white paper in it, have a dry erase marker, and you can write on it and wipe it off. You don't even have to spend money. Or a laminated piece of paper. All of those things can work. Doesn't have to be, quote, a whiteboard, okay? All
Okay.
right, let's get going. Week 5, chapters 23, 24. It's going quick, very quick. The nurse explains that Brian's traction is reserved for children who weigh less than what pounds. Remember, this is the traction used for fractured femurs or hip dysplasia, right? So you have to be less than 30 pounds. The recommended is in between 20 and 30 pounds and under the age of 2. What intervention will the nurse caring for the child in buckskin traction implement? Buckskin traction, again, this is the boot in the lower leg. It pulls when you have a fractured femur, right? What's our biggest concern about fractured femurs and our traction? So the big thing is that number one, you want to have the heel off the end of the bed, right? You want it straight alignment. And this child, because it's pulling this traction, they need help getting pulled up in bed. Some older children, they'll put like this little triangle. It's called a trapeze, and they can pull it. But young kids need help pulling up, and that's to keep it straight. What pain management would be most appropriate for a child status post fractured femur repair? I talked about this little bit. We have mild to moderate, moderate to severe. What's appropriate for a fractured femur? So fractured femur is really bad pain. Think about these little the femur is cracked, it's got sharp edges, it's touching all of the thigh muscles and nerves, causing muscle spasms, and it's swelling in there. It hurts. They need opioids. And that low dose analgesia around the clock, this would be the perfect person for that. What will the nurse include when caring for a child in Buck's traction? What do you need to do for this kid? Remember, Buck's traction, Buck's extension, that's keeping that femur straight, right? What's our concern? It's always checking for that skin irritation. Because remember, you've got this thing, this boot on, and it can cause, some irritation. Plus, it's there on the bed and it could be creating some sort of sore in the back of it. Also, what's the other thing we do with these sort of traction? What's important that we do every time we walk in the room? We have a child that has a fractured femur.
Neurovascular checks.
There we go. Making sure the blood is flowing where it should be going. Very good. Thank you. What is included in the definition of pain according to the Academy of Pediatrics? What is pain? Pain is whatever they say it is, isn't it? I mean, they used to say, well, that child or that person don't look like pain, and they say they don't need anything. Well, we know that don't everybody respond to pain differently. So that's why it is. Pain is whatever the client says it is whenever the client says it does. Okay. They say they're in an 8 pain, they're in an 8 pain. What statement by the mother indicates understanding how to administer oral antibiotics for otitis media? So, what is otitis media? It's a middle ear infection, right? What's one of the big things besides, yes, it's an infection? Remember, it hurts. And one thing that we have to teach them is make sure we keep them comfortable, right? So, With having otitis media, like any other infection that requires antibiotic, you're going to administer the prescribed doses until it's all done. You can't say, oh, it's all better, let's stop, because then that infection will just recome, and then you're starting back from square one again. So continue all the medicine. A multi. What is the best way for the nurse to communicate with a 10-year-old child who has a hearing impairment? So if you can't hear, the best way is you want to be in front of that child face to face. Remember, not over, eye level next to them, and then looking at them, and then the very short sentences, and not over exaggerating it. You tend to want to talk louder, you want to over exaggerate, and that's not what we should do. Short sentences and just talk normally, face to face, eye to eye. What is the best way for the nurse to communicate with a child who's a hearing impairment? There's something else there, more of them. So again, this is talking in those short sentences, and clearly for them. The nurse is reviewing the characteristics of Ewing sarcoma, which statement indicates an understanding of this disease. Well, remember, we're talking osteosarcoma, Ewing sarcoma. What is that? Remember, this is the marrow. The bone marrow is the Ewing sarcoma. The thing with Ewing sarcoma, it's in the marrow, and that one of the things is the treatment is radiation and chemotherapy. It tends to work really well with Ewing sarcoma. Surgery isn't always a possibility with this, like osteosarcoma of the femur. We can take that bone out that I discussed with you. What characteristic manifestation does a nurse caring for a child with Duchenne muscular dystrophy document? Well, what is Duchenne muscular dystrophy? And what would we start to see in these children? So all of a sudden, this child is, used to walk or attempting to walk, and all of a sudden they get to the point they're falling a lot more and they're looking more clumsy, okay? And these children, remember, they are mostly cognitively delayed, all different levels of. So it's a lot of observation with these children and that sort of assessment. They're going to have issues with gross motor skills and fine motor skills too. The nurse is providing instructions about how to treat a sprained ankle, a statement that needs additional treatment, which means something that needs additional. What's wrong here? What do they need to understand better? So, do you remember the acronym that we used when we're looking at sprained ankles and what the treatment is? Does anybody remember?
Right.
Rice.
There you go. Rest, ice, contain, elevate. When you put warm on it, it causes vasodilatation. And what does that cause? More swelling, and that is more pain. So, yes, they don't need to put warm, they need to be cold. Very good. How is pain managed the most effective way? So the one thing about pain is if we, and this is, it does work very well. Low dose analgesics on time around the clock. That's not, oh, I'm hurting, PRN, let me give something. That means if it's every 4 hours, to give it every 4 hours, but a low dose. And that keeps a continuous amount of medicine on that child so they don't have this breakthrough pain. And it is the best way, especially like a fractured femur or post appendectomy, that they are, and you know they have pain. How does Russell traction provide adequate skin traction? Well, remember, what is Russell traction for? Russell traction is like Buck's traction, right? And it is for a fractured femur. But what it does, it's got that extra sling in there. So it pulls this way and out. So it holds it in a really good position so those bones don't come apart, right? Because remember, those bones have sharp edges and they hurt. Finding with the nurse assessing the neurovascular signs of a child in Russell traction report immediately. Remember, Russell traction, children less than 2, 20 to 30 pounds. We use it for fractured femurs, dysplasia of the hip. What would be concerning? Well, again, what are we checking? Neurovascular signs. What is a concern? Bluish color, pale color, pain, all of those pains, all the P's, right? But the bluish discoloration. What do you do if you see that? You're going to tell somebody, right? Call the doctor, tell the charge nurse, something's wrong here. What intervention is appropriate for a nurse assessing a pre-adolescent child for scoliosis? Remember, pre-adolescence is when they do that big growth spurt, 20 to 25% of their height. So it's pretty quick. So they bend forward, yes, and you're going to see, there's going to be an arm longer, and you're going to see one shoulder or one hip is crooked, and that would be the telltale sign. We treat scoliosis with physical therapy and a brace usually. Sometimes it goes surgical, but mostly that will work. What nursing action will significantly decrease the risk of serious complications for a child in Bryant's traction? So what are you worried about the most, Bryant's traction? Hip dysplasia, fractured femur? What are complications that you're worried about? And again, is blood flowing the way it should? Remember, with these things, there are swelling. Are they in good position? Is blood getting to the toes where they should go? Okay. Which intervention would be helpful in relieving morning discomfort associated with juvenile rheumatoid arthritis? Remember, juvenile rheumatoid or JIA, JRA, it's the joints are swollen. What happens after sleeping all night long? You're not moving, right? How do you treat JIA? It's that keeping that movement, keeping those joints going. So if there you had the knee that always bothers you, or the wrist or that ankle, whatever it is, put a nice moist heat pack on it before you get up. It will loosen it up and you'll be able to get up and be in less pain. What instructions would the nurse provide to an adolescent who's fitted with a Milwaukee brace? That's the name of the brace that we use for scoliosis. That's the proper name. So when they use these braces, it's 23 hours a day, 7 days a week, and physical therapy to strengthen the muscles to help straighten out as well as we can that spine. What they do is they put a t-shirt underneath, for that rubbing. No lotions, no powders, because it can clump and that can cause more problems there. And it's something that we don't want to have, okay? Angela, where did you go, my dear? Lauren, please keep yourself on camera, please. Which observation makes the nurse consider the possibility of child abuse when a mother says her young child fell? Now, this happens all the time, right? Children always are falling off of, beds and couches and monkey bars and whatever. Now, what's going to tell you something's wrong here? Well, when we look at bruises, we look at the color and we can determine how long they've been there. And if there's all different types of colors on this child, it could have been 7 days ago, 5 days ago, it happened. And they're telling me it just happened. And now they're concerned. This would bring up a big red flag. So let's go look and check this child a little bit carefully. Sometimes you got to move them away from each other in order to do those sort of things. On entering the room of a child in Buck's traction, which observation requires a nursing intervention? Remember, in a Buck's traction, why are they there? They're there because they have a fractured femur, right? So, what observation? You want that pull to be continuous to keep those femur bones, straight. If it is sitting against the end of the bed, pull isn't there. Those bones could pop apart. And now you've gone backwards in the care. That bone little callus is trying to form, it's going to be gone. So always make sure the heels are away from the head of the bed. What type of fracture would be the most likely to alert the nurse to the possibility of physical abuse? Remember, it's the spiral one where they take the hand and they turn it quick and pull it. So it's like a twisting, and it could be the leg too. As I said before during the lecture, this is the one that might be the only thing that alerts you a child is being abused. And remember, as a nurse, it's your responsibility to keep children safe. And remember, by law, you are protected for reporting that. So it's something that as nurses, we need to be aware of. A multi. What factor may trigger abuse in a parent? Why would a parent abuse a child? And it's been researched that a lot of these factors could be the reason. So, substance abuse, alcohol, or drugs, low self esteem can cause it. If they were abused, they're just overwhelmed, overworked, that overwhelming responsibility. And then, of course, finances, homelessness, and all of those things. So, many things can trigger it. It doesn't, right, but
I
it's
got a
something,
question about that.
sure.
With the knowledge deficit relative to childcare, wouldn't that be an answer? Because if they ain't familiar, like if they got an autistic child or something and they not sure about how to handle them and stuff, that could lead to, or am I reading too far into it?
Well, you're reading into it, but you know something, you're not wrong. Yeah, sometimes they think that they have to be rougher with the kid to make them understand. I see what you're saying there. That's a very good point. Yeah, it could be. I'll agree with you there.
Okay,
Thank
because
you.
I picked that one, but it marked it
I
wrong.
thought
So
the
I was just
same
trying to
thing.
understand why I got it wrong.
No, looking at it and the way your explanation, it does sound reasonable to me. But we know when it goes too far too. So there's a fine line because it doesn't mean that you can punch your kid because of they've done something wrong. So it goes up to a certain level. Okay? Thank you.
Okay.
Can you mute me? I can't mute it.
What assessment by the school nurse would lead to the suspicion of strabismus? So, what is strabismus? Isn't that when they're cross-eyed, right? So there's things that would happen. Yes, they're going to cover one eye because they can't focus with both eyes. Covering one eye would be one of the biggest things they'd see. They could maybe, if they're there too long, might complain of a headache. But the biggest thing, but headache could be anything, right? When they cover the eye because that one eye works by itself together, he gets confused. He can't see correctly. What might the nurse explain as a common treatment for amblyopia? What is amblyopia? Amblyopia is the lazy eye, right? The eye doesn't sit correctly. How do you make that muscle and that eye work better? Well, it's a muscle. You have to strengthen it. You cover the good eye, make the bad eye work a couple times a day. Sometimes it's, every 4 hours for 1 hour, have the eye covered, let the eye work and get that muscle strengthened. And that's usually you can get the eye strengthened and stop that lazy eye, that amblyopia.
They have those really cute eye patch charts
Yes,
now for
they
kids.
do. What assessment does the school nurse recognize as a cardinal sign of hypema? What's a hypema? They've got all neat eye patches. I've seen them in tigers and rainbows and all sorts of stuff for those kids who can see it. Yes, they do have great eye patches today. Hypema is that dark red spot in the iris, and it's something that should be looked at, investigated, but it should eventually go away by itself. What type of fracture is an incomplete fracture where one side of the bone is bent and the other is broken? So again, this is just a definition you should remember. It's called a green stick one. Very good. You did good with that. A simple fracture is just a crack, very simply. Doesn't even displace. What does a nurse explain to parents of a child with febrile seizures? What are febrile seizures? Does that mean I have epilepsy with febrile seizures? That's the parent's biggest comment when they come in with a child who's just had a febrile seizure. And what it is you have no fever, half an hour later, quickly it goes above 102. So it's the rate of rise. And that's what causes it. The brain sparks, says, I don't get it. And then you have a seizure. Usually by the age of about 6, they'll grow out of it. My grandson did. What type of fracture is associated with child abuse? Again, that spiral, that's that crack. It turns around, it spirals. Very good. A multi. What factors may trigger a parent to abuse their children? Give you another one to look at. So it's all of the above, and yes, very good. Child experiences episodes where he appears to be staring into space. What type of seizure is that? Everybody say it's like a blank stare. And it's called an absent seizure. Very good. What is an appropriate nursing action when a child is experiencing a generalized tonic-clonic seizure? So their arms, their legs going, there's foaming at the mouth. They could be incontinent of bowel or bladder. What is our biggest concern about all of this? So the thing is, kids always have stuff in their bed, right? They start moving and thrashing, they could hurt themselves, get, all sorts of lacerations with it. So the thing with this is move it out. Now, turn them on their side, have suction in case we need to suction vomit that's not their mouth, but around them where their mouth is so they can still breathe. Okay. And then, of course, call somebody in there to help you with it. Nothing ever in the mouth. If they're on the floor and they're having a seizure, leave them there. Okay. It's the best thing, and you never restrain them. Good. The legs of a child with CP crosses involuntarily, and you have jerky movements with his arms. The type of cerebral palsy is this one. Involuntary jerky movements. And that's the most common of all of them, called spastic cerebral palsy. Which assessment finding in a child with meningitis should be reported immediately? Meningitis, brain and meninges, has an infection. What's the big concern? And that's all about their blood pressure. Which nursing assessment suggests the child has a concussion after a child fell and hit his head on the ground? What are we concerned about with any head injury? And how do we measure it's getting worse? And, this is telling you, okay, I've had a concussion, I was knocked out, or I've had a bad jerk to my head. And now, when I slid into third base, was I safe? Did I make it? Did we win the game? They start asking the same things over and over again. They're that confusion. They don't remember. And last question. A 6-month-old child gets inoculated with Haemophilus influenza type B. What does this immunization protect against? Again, this was, part of PowerPoint that I read today. And it is influenza. Let's see how we did today. A lot of different stuff here. Me, a Jekka, good job, Jekka, and me. Number one, Mila, good job, Mila. And Lucinda, and another me. So, long class today, a lot of stuff that we did. Remember, next week we are going to be having our exam, so come in a little bit earlier. I did send out the recording for you. Make sure you review PowerPoints, the Kahoots, you know, your study guide. Listen to at least somebody with a review, me, somebody else, and actually the two views minimal that will help you get through it. All right. I'll see you guys all next week. Anybody who wants to review with me, you let me know. Okay.
Okay, Professor. Thank you.
Thank you.
Thank
Good
you.
night.
Good night.
Good night.